Hello, everyone. Today, I would like to discuss with you a very important topic that often is not really addressed in the literature, and that is the problem associated with uh, minor surgical procedures such as knee arthroscopy, distal fractures in the leg, Achilles repair, quad rupture repair. These are relatively simple surgical procedures, and they're not usually thought to be associated with a high risk of venous thrombosis. The surgical procedures are quick, they're relatively simple, and they don't in any way have the same degree of risk as a total hip or total knee replacement, for example, or a major hip fracture. However, what's often forgotten is that these more minor surgical procedures associated with minor fractures and injuries can still be a very at very that patients can still be a very high risk of venous thrombosis because of the associated factors that the patients bring to the table. Often we talk about that as baggage. If they have a history of thrombosis, obstetrical complications, family history of thrombosis, cancer, inflammatory bowel disease, and so forth. So that's one set of baggage. Another set of baggage is associated with the procedure: immobility, straight leg bracing, non-weight bearing. And these are other things that factor into the equation. And usually, when a huge problem occurs, it occurs because of a collection of smaller problems. And we're going to discuss that today because there's nothing more tragic than a skilled orthopedic surgeon doing a marvelous procedure to restore a person to full activity, only to have that person die of a fatal blood clot. Only to have that person die of a fatal blood clot. Not, of course, especially a young person, but any person of any age. So let's explore that a little bit. And in order to do that, we have to talk about fractures. And let's start with the fracture itself. Now, some fractures are very simple. They're non-displaced, and although the bone is broken, nothing has to be done surgically. Sometimes they don't even need a closed reduction, and they usually, though, require casting or immobilization. However, even in smaller fractures that don't require any surgery, when a fracture occurs, there's bleeding around that fracture, and that causes the blood to be stasis or puddle like a stagnant pond. In addition to that, and this is often not talked about or thought about, but if you have a force great enough to cause the bone to break, the tissues are also damaged, especially the delicate lining of the venous vasculature, and that results in vascular damage. In addition to that, there's disruption of the marrow, and that can enter the circulation and increase coagulation. And also, the damaged bone and soft tissue remnants can enter the circulation, and these factors all will increase coagulation. So we have stasis, vascular damage, and hypercoagulability. And we know these as Virchow's triad. Now, who was Virchow? Virchow was a famous pathologist that lived in the 1800s, and he came up with the three factors that are associated with blood clots. And they were vessel wall injury, venous stasis, and hypercoagulability. Here we see a picture of his lecture hall called Virchow's Cabinet that was partially restored but kept as sort of a relic to the war. And this is in the Hospital Charité, which is 3 blocks from the original cabaret in East Berlin. And when you take a look at these three factors, Virchow postulated that if all three factors are present, as seen in this diagram in the triangle, the incidence of venous thrombosis is very likely. So we have vascular damage, venous stasis, and hypercoagulability. And remember, the force required to break the bone, I'm repeating this because this is often not appreciated. The force required to break the bone also damages soft tissues, including the blood vessel linings in the area. And if you have puddled blood and damaged lining of the blood vessels, and those subjects of the tissue damage and bone are getting into the circulation, you've got hypercoagulability. It's a perfect setup for a blood clot. And this allows, of course, the blood to escape into the tissues, stimulating coagulation and the bone marrow injury. Again, I'm repeating this because this really is important. This occurs with these fractures. The bone marrow and tissue juice gets into the circulation and causes hypercoagulability. And then there's a local stagnation of blood because of the breakage and the hematoma formation. Here's a 1,000,000 power micrograph, performed by a brilliant vascular surgeon and researcher, Tony Camerata. And it shows the damage to the vessel, the venous wall, and the tears in the venous wall. And this can occur when the vein gets overstretched or when there's trauma, such as a force enough to break a bone. And when that happens, there's subendothelial collagen here in these tears, and that's where the blood clots start to form. Now, I'd like to show you a cartoon of a white cell that changes into an adhesion molecule. And this adhesion molecule actually slows down and attaches itself to the vessel wall. And when it does, it'll finally come to rest. And then there will be an extrusion of granules, which create an inflammatory response, which damages the wall of the capillary. Now this capillary can no longer function to exchange nutrients, waste products, and oxygen. Here is an actual picture of the experiment with the adhesion molecule penetrating the capillary endothelium. Another problem, which is often not fully appreciated, is that this is a knee slightly bent, and when it's extended, then the vein, popliteal vein behind the knee, becomes occluded. And when that happens, the blood flow out of the leg is slowed down, and it has to go in alternate channels through the surface veins to get out of the distal leg below the knee. And this, of course, results in serious venous stasis because the superficial veins are not as efficient as this deep vein in emptying the blood. And on top of that, you all are probably familiar with this because I'm sure somewhere along the line you've heard that people standing at attention, guards and so forth, are not supposed to lock their knees for fear of them fainting because of a decrease in blood flow. Here it is again, bent and then slightly bent and then fully extended. So now let's talk about a person having a simple operative procedure, an arthroscopy, repair of a quadriceps tendon, Achilles repair, or even a distal leg fracture, minor. The contributing factors to this include the presence of the fracture, and right there is all of Virchow's factors to start a clot, and the surgical repair, especially if tourniquets are used. And then things like obesity, leg swelling, immobility, and straight leg brace. These additional factors, all by themselves, not really that significant in terms of producing a DVT. But when you add all of those together, then all of a sudden the risk becomes from low to, in some cases, very, very high. And we talk about, and I'd like to repeat, the extension of the knee, the popliteal muscle, can block the popliteal vein and slow blood flow down. By the same token is that we know there are good definitions, and here's the reference, which is often not looked at, that ambulation is defined as walking 30 feet using both legs. If one leg is immobile, then first of all, that doesn't count as ambulation. And also a non-weight bearing leg, There is no increase in blood flow over that if the patient is sitting. And that's even with flexion of the hip and the ankle. Again, the Craik duplex scan study clearly shows that. And casts, especially in the equinus position, are also associated with reduced blood flow. Now here we see a fatal pulmonary embolus. And this is the pulmonary artery, the main artery, and this is an embolus in this at autopsy. And what's really disturbing is that pulmonary embolism mortality has increased over the past decade, despite all of the efforts and all of the data and all of the research to prevent this. Why? We have enough data, which I'm going to show you. We have the algorithm to prevent the majority of these deaths. So why is that occurring? Well, we'll get to that because I think there's a very special disconnect. First of all, here's the data. This is only one paper, but this is a very important one because it's 23,000 surgical patients that all got either heparin or low molecular weight heparin. Almost over 20% of them were orthopedic, mostly non-joint replacement patients, these simple patients that we're talking about. And the endpoint was autopsy adjudicated fatal pulmonary emboli, the ultimate endpoint. And as you can see, the incidence of fatal PE was 0.1%, regardless of which anticoagulant was used. Now, there were no deaths from anticoagulant bleeding in this large series. There were patients that got clots, but only a 0.1% of them died. I might note for those of you who are scholars and know about this, you'll know that there were some people that took exception to this article saying that there were a few patients that weren't autopsied. So the authors rebutted and came back and said, we'll count all of those patients that failed to have an autopsy as also dying of a fatal pulmonary embolus. And that increased the number of deaths from 0.1% to 0.005%. So again, heparin or low molecular weight heparin has been shown to consistently eliminate death in almost all patients, surgical patients who have had from pulmonary emboli. And the punchline here is that all patients received at least 7 days of anticoagulant prophylaxis, which is a period of time shown in 146 trials in 43,000 patients over 3.5 decades to be the period that's efficacious for the prevention of a venous thromboembolism. Not while they're in the hospital, not just 2 or 3 days, not one dose, but 7 days at least of prophylaxis. Now let's talk about the Caprini score. Now there's many roads to Rome. And I know especially in orthopedics, they've been slow to accept this score. But I'd like to discuss that a little more thoroughly and sort of dig into it. First of all, it's a thorough history and physical and comprising 40 elements. And we know that as the number of risk factors goes up, the risk of venous thrombosis increases. We also know that there are certain risk factors that are low power, such as bed rest or immobility, and certain risk factors that are high power, like cancer of the esophagus or the pancreas. So taking the number of risk factors and their power, we combine those, and that comes up in a score, a weighted score that represents a nonlinear increase in clinical VTE rate with increasing score. Here are the results in general surgery, and the score has been validated in over 5 million patients, including 420 publications worldwide. And I'd like to stop right here and say that I am greatly indebted to all of the people around the world on 5 continents that have helped with this and critiqued it and showed where it works, showed where it doesn't work, showed where it needs to be improved. And so this has been a very powerful thing. And we will talk about how this has now been applied in orthopedics a little later in this lecture. Well, now I've shown you the data, and I've shown you one comprehensive risk scoring system which could be used to apply the data to patients who are at to determine who is at high risk of thrombosis. What's the disconnect? Well, the disconnect is that between evidence and execution as it relates to VTE prevention. Just like there's a disconnect between the rider and the motorcycle, in order to reduce the deaths, you've got to not only take the data, do the risk assessment, but apply it consistently and in a uniform fashion in a plan of care to eliminate venous thromboembolism. Now, here is a classic example of how that's done. The Boston University had a high incidence of venous thrombosis in their general surgical population, and they instituted certain measures. This is the national average in green. They instituted certain measures in over 2 years, including a ICOF program and the Caprini risk assessment, and they brought it down to a very low level. How did they do this? Well, there was a mandatory algorithm, and if the score was 0 to 4, you could do what you want in the hospital. If the score was 7, if it was 5 to 8, you had to give 7 to 10 days of low molecular weight heparin injections. Didn't make any difference whether or not the patient went home or not. And 89% initially complied with that. However, if the patient had a score of 9 and above, 30 days of low molecular weight heparin injections had to be given, and 3/4 of the patients and their doctors complied with this, which contributed into these low incidence of thrombosis. Now, the other thing is that the Boston University is the #1 safety net hospital in the New England area, responsible for the care of the indigents. And they're also for the care of a wide variety of people in the Boston area. They worked out a deal with the insurance companies and the providers and the drug companies that any patient that needed this prophylaxis would get it regardless of their ability to pay. And I think this is a poster child for the United States. We'll see a little later how that applies in orthopedics. But for now, just note this. It even gets better. This program has been sustained for over a decade. And there again, you see the complete program up there with the 7 to 10 days and the 30 days. Now, what happened here was, first of all, you saw that 89% in one group and 77% in the other group complied. Now, those that didn't comply, they weren't yelled at or brought into the chairman or anything. They just had to list a reason why they didn't want to give the prophylaxis. But over time, those skeptics saw the success of the program, so they wanted to join in on that success in order to benefit their patients. And that was an ideal nudge by example, to encourage people to do this missing link. And these people have published 18 papers. And at the bottom, you can see the latest paper. There's 18 papers describing this technique in a variety of patients. Let's turn now to orthopedics. There was a study in New York where patients were being studied in this orthopedic department and classified as high or low risk. They were high risk if they had a VTE within the prior year, BMI of over 40, additional comorbidities, active malignancy, bilateral stage joint replacement, and inherited or acquired thrombophilia. And by the way, these criteria have been commonly used throughout the orthopedic community to divide total joint patients into high and low risk. Well, they did that over a 15-month period, and they decided that patients who were at low risk would be treated with aspirin, and those that were at high risk received conventional anticoagulation, usually a direct oral anticoagulant. So after that 15-month period was over and the results were blindly, the Caprini score had been collected. It was never revealed, it was collected. And then at the end of the study period, when the results were in, then the Caprini score was compared to the department stratification. Remember, I showed you the criteria for the department stratification. And so all but one of those These are the patients that got a clot. And all but one of those patients, according to the department stratification, were classified as low risk. So it was only one high risk patient. It was just the opposite with the Caprini score, whereas there was only one low risk patient. And that actually was somewhat of a mistake because that patient actually had a history that was missed in the beginning. And when they came in with a clot, it was finally uncovered. So it was shown that the Caprini score was, of course, vastly better than using the department criteria. Well, based on that, a follow-up study was done where then patients who had total hip, total knee replacement, or revision hip or knee replacement, or staged bilateral procedures by 13 surgeons in one institution were given a standard protocol. The protocol involved using the 2013 version of the Caprini risk score, and those patients that had a score of less than 10 were given aspirin. If the total hips were given aspirin for 81 milligrams, Q12 hours for 6 weeks. And if they were in the high risk group, they got apixaban 2.5 milligrams every 12 hours for 35 days. Knee patients, if they were low risk, they got aspirin again for 6 weeks. If they were high risk, they got apixaban for the first 12 days and then aspirin for the remainder. And so you have 873 patients, 60% of them were low risk, 40% were high risk. And I want to point out something here, which is missed in many, many studies. The Caprini score, but not only the Caprini score, any score is a dynamic tool. And during hospitalization, things occur. And for example, in this series, a change in score occurred for 21 of these patients with a change in the treatment regimen in 13, low risk to high risk, due to limited mobility, blood transfusions, or need for immobilizer. Remember the dynamic nature of scoring. You can't just do it once on admission. So what were their outcomes? Overall rate of VTE was 0.2%. Prior to the implementation of this score, it was 0.78%. Symptomatic VTE after total knee replacement was 0.35%, both distal DVTs. Symptomatic VTE after total hip, 0. Minimal minor bleeding outcomes you can see here with aspirin and with apixaban. Outstanding results. And these are again depicted in a different chart so that you can see these results. And this program is continuing till the present time because it's been so successful. Now let's talk about another problem, which I think I'm very, very intense about because of how this is missed, and that is the preoperative scanning of very high-risk patients. Now, of course, the CHEST consensus guidelines doesn't recommend routine preoperative duplex scanning for total hip repair, but that's not what I'm talking about here. I'm talking about a duplex scan for cause, and that cause is a very high-risk preoperative patient. And I'd like to show the results in hip fracture surgery to illustrate the importance of this point. These were 92 patients who were evaluated for their risk according to clinical signs D-dimer, risk assessment, Wells score, and Caprini score, and they all underwent preoperative Doppler scanning. The incidence of preoperative DVT was 16%, 15 of the patients. All of these patients who had acute DV were treated successfully with an IVC filter or subcutaneous enoxaparin before hip fracture surgery and had successful surgery. The DVT group showed a higher Wells score and a Caprini score compared to the non-DVT group. The sensitivity and specificity are right here, 47 and 81 and 93 and 35 for the Caprini score. So the Caprini score was 93% sensitive. Conclusions: those with a score of equal to or greater than 12 should be screened with Doppler ultrasonography preoperatively. Those with a Wells score of 0 to 1 had a low risk for preoperative DVT. But I'd like to reemphasize this. There are other studies out there that I could quote that show that preoperative scanning can unmask In very high-risk patients now, not routinely, but in very high-risk patients. And in order to find out who is high risk, you've got to do a good score to see who is really high risk. So in conclusion, serious or fatal blood clots can occur in orthopedic patients who are at high risk. Fatal pulmonary emboli are the #1 preventable cause of death postoperatively. The procedure plus the patient's individual risk factors determine the level of risk. Fatal pulmonary emboli can be prevented with mandatory use of an evidence-based algorithm, combining known data with risk factor stratification using the Caprini score. It's not the only road to Rome, but it's a very successful road to Rome. Caprini scores of less than 10 should receive aspirin, while those with higher scores benefit from traditional anticoagulants, including the direct oral anticoagulants. Score of 9 or less are good candidates to receive aspirin prophylaxis, and the aspirin should be administered at least 2 hours before Selexcab to maintain the effectiveness of the aspirin. When you don't do that, the effectiveness is diminished, and the Northwell group in New York has shown this. Hip fracture patients with a score of 12 or more should be screened preoperatively. So in summary, I'd like to finally say, never kill a friend, never treat a stranger. Now, what do we mean by that? Well, when you meet somebody, you've got to perform a thorough history and physical, so you have knowledge about your patient as if they were a good friend. Call it the Caprini score, call it any score, but you've got to interrogate the patient with all of the important risk factors that can cause a fatal blood clot. And once you do that, of course, you'd protect them. So you'd never kill a friend, but you'd never treat a stranger. Please visit my social media platforms for more information, and I'd like to thank you very much for your attention during this lecture.